Hi, I'm Dr. Bob Dannenhoffer today with another of our Facebook Live sessions. It's April the 13th, and this is our chance to answer your questions. So if you have questions, please do it. We've already had some people submit questions on Facebook questions at douglaspublichealthnetwork.org, and we'll do those first, but we'll get to everybody's questions today. It's a beautiful day, and I hope that fewer and fewer people are watching because things are getting better and people are less worried, and I would love to get to a point where there's really nothing exciting to say and we go home at 6:10, we're done. Still, there's a lot of exciting stuff this week, so that's not happening yet, but that's my hope. So, as always, we start at the world level and then move down, and this is our time to answer your questions. So if you have questions, put them in the chat section, and Vanessa is going to get them to me, and we'll try and answer those questions. So in the world, still very active, 136 million cases, 2.9 million deaths, and in the world they peaked around the New Year's and then went way down, but now it's back up almost to where it was before. So very clearly in the rest of the world there's a fourth peak, and they're back nearly the wintertime highs. Actually, at the end of last week they had one of the second highest day ever. So this disease is clearly not past us in the world. We're seeing a lot of disease in Europe, South America, India. And India is really worrisome for two reasons. One, a very densely populated country where even when they have a low rate of disease, still has lots of cases. And because of the crowding, we really worry about variants. And already there's a thing called the double variant that comes from India, which is the most worrisome variant so far. So we worry about the world situation. In the U.S., we're 31 million cases, 561,000 deaths. But deaths have really been down and have stayed down now for the last few weeks. And even though the number of cases is slightly increasing, the number of deaths continues to go down, and that is a good thing. I mean, I'll tell you that, cases worry us, but it's really the deaths that are problematic. We're averaging still 761 deaths a day, but that's a whole lot better than we were before. We are starting to see hospitalizations in the country go up, and unfortunately, hospitalizations sometimes presage deaths. What we see in the U.S. when you look here is a very uneven picture. So there are some places like Michigan, Minnesota, Texas Panhandle that are just flaming hot. Lots of cases, 60, 80 per 100,000 per day, and then whole huge swaths of the country where there's less than 10 cases per 100,000 per day. So it's kind of a funny tale of two worlds here. We're also seeing lots of disease in Florida, New York, and New Jersey. Now, the disease back east is driven very much by this B117 variant. So Michigan, which is really the worst, has almost about half of their cases are the B117 variants. So it's really worrisome what's happening back east, because there's nothing to suggest that if this variant now spreads to other states that they won't have the same explosion that Michigan does. Michigan has got about an average rate of immunization. They actually had a higher than average rate of previous infection, and despite that, the disease is really spreading in Michigan. In Oregon, we have a clear uptick in cases. So a few weeks ago, it was really quiet everywhere except Douglas County, interestingly, and now Douglas County is quieter, but the rest of the state is now kind of taken off. We're seeing an increase in cases, an increase in hospitalizations, but not yet an increase in deaths. So we do worry about that. Disease is active in the Portland area, active in Josephine and Klamath counties, and in some of the eastern Oregon counties, which really not have had a lot of disease, they're now starting to see some disease. So it's a little bit worrisome here. Douglas County, we're incredibly flat. I pulled the numbers for each of the last 2-week periods, and it was like 140, 140, 140, so it was very close. This time, we are, when I looked here, we're at 88 over the last 10 days, averaging 8.8 cases. If we continue that over that, we'll be just at that 112 level. That if we get underneath that, we can go to the moderate range. If we're above that, we'll stay in the high range. So we're close, but it all depends upon how many cases we get in the next few days. So that's a question. Now, I will tell you, when we look at our cases, almost all of these are in unvaccinated people. And there are a lot of people now who are eligible to have gotten vaccine. First responders, teachers, educators, healthcare personnel, people who are over 75, all have been eligible for at least a month. And when we see cases in those people, they're almost all unvaccinated. There's occasional one or two that's a breakthrough case, and we'll talk a little bit about breakthrough cases later. But almost all of those are in unvaccinated people. And we know that among healthcare, about 60% are vaccinated. Among educators, 50 to 60% are vaccinated. So if the vaccine wasn't working, you'd expect to see an even number of cases. But it's overwhelmingly in the unvaccinated, suggesting the vaccine still does work. Now, Oregon has had some breakthrough cases, and we've had some breakthrough cases. We did have a breakthrough case reported last week, and we do variant analysis on all of them. Now, you can't do the variant analysis on everyone. You have to have a high enough viral load in the specimen to be able to do the genomic analysis. So we've sent some up, and they said, well, there just wasn't enough genetic material to test for that. But we did have one last week in somebody who was fully vaccinated, and they had the California variant, which is the most predominant one in Oregon. So remember, back east, depending on how you're looking at back east, and it's the B117 variant, but out west is the 429 variant. And the 429 variant is a little more contagious than the previous, but it's less sensitive to the antibodies in the vaccine, so that you can get breakthrough cases and you can get secondary infections. Whereas the B117 seems to respond well to the vaccine, but it's much more contagious. So you have these two variants that are circulating, and the variants are really what worries me a lot. In terms of testing, we continue to do a lot of testing. Our testing numbers are very flat. Our positivity rate is now less than 3%, a very low rate. And so people always wonder if we have fewer cases just because you're not testing as much. And no, you look at your positivity rate. Your positivity rate is the number of positives over the total number of tests. So if you didn't do very much testing, your positivity rate would go up. And if your positivity rate, while your case rate went down, you'd have to think maybe it wasn't testing, but that's not what we're seeing. What we're seeing is our positivity rate is going down at the same time our case rate is going down, suggesting there's less disease in the community. Vaccines, lots of news about vaccines. I'm certain there'll be a question. We're continuing to give a lot of the Moderna and the Pfizer vaccine. No safety signals there. Everybody's probably heard by now that they paused the J&J vaccine, and we'll get to the questions, and if people have questions about the J&J or the AstraZeneca, we'll get there. So let me go through the questions here and see what we got. So Charlie says, based on the current vaccination and infection rate, when do you think we will get herd immunity here in Douglas County? So herd immunity means that enough people are immune to a disease that it really can't spread. So for example, with measles, once 95% of the people are immune, if a case of measles gets into the community, it just won't spread. There's a way to calculate that. It's 1 minus 1 over the basic reproductive number. Now with the B117, the basic reproductive number is 5. So if you can do math in your head, it's 1 minus 1 over 5, which suggests we would have to get to 80%. The original one had an R of about 3.5, which suggests you need to get at 60 or 70%. But I think what you'll see is the vaccination and infection rate will start to rise, and as the vaccination and infection rate starts to rise, the number of cases will go down. I think we've already started to see that. The number of severe cases among elderly vaccinated people will go down. We've already seen that. And overall, the situation will get better, and I think we've seen that. So it's not like things are bad, then boom, all of a sudden it gets great. Basically what will happen is it'll just gradually get better. We know that our background rate in Oregon is about 6.7%. So we think 6.7% of people previously have been infected. We think in Douglas County it's about 5% of the people in Douglas County have had that. So what you add together is the previous infection rate 5% plus the vaccinated rate, which is about 21% now, so that we would have about 26% of the people in Douglas County who are immune. And with that, we would expect the rate of disease to be decreased, and that's what we've seen. But it's not going to go away until we get a much higher rate, 60 or 80%. And a lot of that depends upon how much people take the vaccine. Right now, we've got plenty of vaccine, And so the issue is not enough vaccine. The issue now is people are still a little hesitant. So last Friday, I mentioned that one person in Douglas County tested positive for COVID after being fully vaccinated, and I did say that. I then saw that the OHA announced that statewide 168 fully vaccinated people also tested positive. Can you give us details confirming if they are having low-key symptoms or not, or if there's any other genetic testing results on the other? So we were the first one. I mean, this is not what we want to be first on, but we were the first one where the breakthrough case was a variant. So what happened is Oregon pulled that report on Wednesday night, and ours got diagnosed on Thursday, so that's why it wasn't in the report. Most of the people who've had these breakthrough cases have been mildly ill, although there are still 3 deaths in that group. Although if you look at it, that's a big group of people who've been vaccinated, so that there's only been 168 breakthrough cases is not unexpected. I mean, this vaccine is very good, but not 100%. Now, one of the things that was really badly messaged along the way was when Pfizer and J&J said it was 100% protective against hospitalizations and death. And I cautioned at the time that people had to take that with a grain of salt. So here was the story. So in the Moderna and the Pfizer vaccine, you had 20,000 people in the vaccination group, 20,000 people in the other group. You waited until about 200 people had an infection. Turned out that overwhelmingly the infections were in the unvaccinated group. There were about 15 or so infections in the unvaccinated group. None of those were hospitalized or died. But if you took 15 random people with the disease, you could get that none were hospitalized and none died. So when they said this was 100% protective, the confidence interval was down to 80%. So I've never said 100%. What I always said, very effective in preventing hospitalizations and deaths, and that goes along with the data here. So anytime we have a breakthrough case, we are doing variant analysis, and as I said, we've had one breakthrough case that tested positive for a variant. So Stan says, I keep getting mixed signals regarding the COVID vaccine for people who have myasthenia gravis. So myasthenia gravis is one of these autoimmune diseases, and basically what happens with myasthenia gravis is that it attacks the nerves that go to muscles, and so people wind up with weakness. Early on in the disease, people have lid droop, and then overall they can get other kinds of weakness. And so it's one of those autoimmune diseases, and one of the big concerns about this disease is, since the immune system seems to play such a dominant role in this, what do you do with people who have autoimmune disease? And actually, it turns out there are a lot of people with autoimmune diseases. So most people with thyroid disease have thyroid disease from an autoimmune disease called Hashimoto's. Most of the kids with diabetes, we think that's an autoimmune disease. We think that most of the arthritis syndromes, lupus, myasthenia, many of those things are autoimmune diseases, and we really worry about that. Now, when in the studies, they included people who had autoimmune diseases, but they just sort of lumped them all together. So it is possible that there's one autoimmune disease for which this was not a good idea or whatever. So what I have done on that is I check the foundation websites. So, if you've got myasthenia gravis or one of these other uncommon diseases, there's typically a foundation that gathers all the information and advocates for people with that disease. And there's a Myasthenia Gravis Foundation, and they are recommending vaccine for everybody with myasthenia. So I checked last week for lupus. They recommended it also. So they're recommending that. Now, the best way to know this is, and we haven't done this, is to do, after a new thing comes out, you do a registry. So you check all the people with myasthenia, and you say if you've got myasthenia and get the vaccine, you will put you in a registry. And then after 1,000 people with myasthenia get vaccinated, then you check to see how those 1,000 people did. And in our modern day, with computers and all this stuff, we should be able to do that, right? I'm sure there have been 1,000 people with myasthenia who have gotten vaccinated, and we won't know if the vaccine got better or worse until somebody reports something. And this is, again, another incredible failing from this pandemic. We should recognize that this would happen. And what we should have done is done a much better job at parsing that out, because not just myasthenia, it's lupus, it's Hashimoto's, it's all these other things. Does the vaccine in some cases make it worse? Because if it made your myasthenia worse, that would be a terrible thing. The good news is no data that that's happening. But unfortunately, we are finding out about it only as catch can. So Les says, I have a medically fragile daughter that's 7. I'm counting the days till she can get vaccinated and then stay isolated as much as we can. I saw that Pfizer was going to ask for approval for 12 to 15-year-olds, and I think that's correct. They submitted that last week, and then they should get a hearing this week. Again, the Pfizer vaccine has been remarkable in its excellent safety profile, and when they did kids in this age group, it was 100% effective. Now, again, there were only 2,500 kids in the vaccine group, and all of the disease was in the unvaccinated group. So that's where the 100% came in. But if you did this with 2,500, it could easily be, if you did 25,000, it might not be 180 and 0. It could be like 170 and 12 or something, all statistically possible. But still, nonetheless, a very, very, very excellent vaccine, and I hope they move it down to people 12 to 15. The state then is trying to figure out how to do this, because most counties have not figured out how to get Pfizer widely distributed. And so, as has happened more times than I can count during this, they come to Douglas County and say, well, how do you do it? And so we've been working with the rest of the state to try and get them to do that. So Bruce says, would you talk about the odds of Douglas County moving to a lower level of COVID restrictions? So it looks like we would need to have 44 cases over the next 5 days. So we'd have to average less than 9 a day. And so that's just about where we're at. So I think it's a toss of a coin. And so I think it's a toss of a coin if we can move either to the moderate or stay in the high. I do not think we would go to the extreme. So Ashley says, I knew about this. Can you talk about the recent J&J issue? I just got the J&J, and should I be worried? Ashley says. The answer is no. Well, should we? We're worried about everything, right? So the answer is, how high should be your risk of worry? Very low. So let me tell you what we know. And what I know is mostly what I read in the journals and in the newspaper, but I will tell you, I have no firsthand knowledge, right? There's been nobody in Oregon that's had any problems with this. The AstraZeneca vaccine hasn't even been approved in the U.S. So I do not think that, I don't know, I don't have any inside track on this, but let me tell you what I do know. So the AstraZeneca vaccine that came out, so the AstraZeneca vaccine is a chimpanzee adenovirus that is weakened so that it can't infect you, but it can get into your cell, and it gets into your cell, and you make this, and it makes a very nice immune response. What they noted in Europe is that there were a number of people who had unusual clotting problems. And these were unusual, and I think we talked about this 3 weeks ago, and they were unusual because you had clotting and low platelets. So platelets are those tiny little things in the blood. So, there's red cells, which are about that big, and then platelets, which look like little sesame seeds. And there are these tiny little things that go in the blood, and they're the things that help your blood to clot. And there's this most magnificent system that helps your blood to clot. So what happens is you get a cut, platelets get there, and then they say, oh my goodness, there's bleeding, and then they reach out to other platelets by chemical and other mechanisms so that other platelets come together, and then they form this blockade so that the bleeding stops. And it's truly a remarkable system, because there's a dozen or so proteins involved, and then platelets, and then platelet aggregating factors or whatever. It is really truly an amazing system. What we've known for years is that when people get heparin, which is an anticoagulant, and this usually happens if people have heart disease and they're going in for open heart surgery. So when you're going in for open heart surgery, the blood passes through the heart-lung machine, and when it passes through the heart-lung machine, it can't clot in there. So you give the person heparin to help that so no clots form in that system. Well, what they notice in a few percentage of the people who get heparin is that they develop these antibodies to something called platelet factor 4. And then in just a few percent of the people who develop antibodies, those antibodies activate platelet factor 4, so the body thinks that they're having clotting, and all the platelets then aggregate together, and they aggregate together in places they shouldn't aggregate, like in your brain, and they can cause this clotting in the brain. And so they saw this at AstraZeneca, and what happens is, because all the platelets go to the clot, your platelet levels decrease, and you also then have bleeding in other places. So it's this weirdest thing. You have clots in one place, bleeding in other places, and a low platelet count. It's just a bizarre thing. And we've known about this for years. It's rare. I've never seen it. And I've been doing this 40 years, so it's got to be pretty rare if I haven't seen it in 40 years. So I haven't seen it, but I know at the hospital, at the ICU, would occasionally see a case like this related to heparin. Well, they saw this clotting and low platelets thing in these people who'd had no experience with heparin, but they had those same antibodies that people with the heparin thing had, suggesting that the vaccine, the AstraZeneca vaccine, caused them to have this. Well, once we knew that this was happening with the AstraZeneca, they started scouring the U.S., and they found 6 cases in the U.S. where it was mostly young women who got the vaccine a week to 3 later, started having clotting and started having this problem. 1 died, 1 critical illness. And so, we worry about this. And I think because it affects young women who are otherwise relatively low risk for COVID, I think we're especially worried, right? So with vaccines, what you want is a benefit to risk ratio, which is very high. So if you take an old guy like me, the COVID vaccine has a very high benefit to risk ratio. I mean, my chance of dying at this age is pretty high. And the risk of me getting this is very low. There were no 65-year-old men who had this, so my benefit to risk ratio is low. But we're gonna look to see for a 20-year-old woman whose risk of getting this clotting is higher than mine, obviously, and the benefit from the vaccine is lower than mine because 20-year-olds usually don't get very sick. So we're very worried about this. I think the CDC and the FDA did exactly the right thing. Let's stop, take a breath, figure out what's going on. Stop, take a breath, figure out what's going on, and then we'll move on from there. I mean, what the Europeans have done is that they've saved the J&J vaccine for older men, right? Because we don't seem to get the problems from it, and we might have more orphan for older women, and have used other vaccines for younger people. They may do that. I don't know what they're going to do. I have no inside track on this. So Denise says, can you speak to the status of the approval on the Pfizer vaccine for 12 to 15-year-olds? It's been submitted to the FDA last Friday. There's going to be, what happens once they submit it, then the internal staff works on this. Then they have a hearing. I did not see that the hearing has been scheduled yet, but I would think it's likely to happen sometime in the end of April or in May to have approval for the Pfizer vaccine for 12 to 15-year-olds. So Sandra says, is the vaccine at all effective on the new variant, or will there most likely be a new vaccine for that? Well, so let me tell you, new variants come up all the time. So I will tell you about the variants we know about. So the variants that we know about, the biggest one is the B117, which is the UK variant. That UK variant is spread pretty much all through Europe and most of the eastern US. The vaccines seem to be as effective for that as for the previous variant. The Southern California variants, which are the 427 and the 429, and in the South African variant, the vaccine seems to be a little less effective, but still somewhat effective. The concern is not really the variants we know about, but it's the new variants that will develop, right? So once new variants develop, these new variants will tend to spread more if they can pick off both vaccinated and unvaccinated people. So you have to think sometimes of the virus, think about it sort of like the viruses are smart. They're not. They just work by randomly. But if they were smart, one of the ways that they could become the predominant virus was they could infect both vaccinated and unvaccinated people. And that's the concern, is that it's not the variants we know about now, but it's the new variants. Will there be a new vaccine for that? Well, that was on the front page of the Oregonian today, and there may be, just like the flu vaccine changes year to year to look at new variants. It wouldn't be at all surprising that the COVID vaccine would do that. And if I had to bet, the Bob Dannenhoffer bet is that this is going to have great new mRNA technology, and there's going to be a flu COVID booster each year, and everybody gets their flu and COVID booster each year, and then you get protected against both. So Charlene says, how safe is the J&J vaccine for type 1 diabetes? We don't know. So I don't know anything about the background conditions of that. The J&J was tested again on a broad population of people, some of whom may have had type 1 diabetes. At least in the study, there were no signals for people who had underlying diabetes. So Brooklyn says, have you seen any other illness around Roseburg that's causing low-grade fever, sore throats, coughing, nausea, and body aches? Well, certainly those things could be COVID, but we've seen a bunch of people have those symptoms and they don't have COVID. We are terrible at figuring out what causes much of this stuff. So when somebody comes in to see me in the office, there are only a couple of diseases that, let you know a secret here, there's only a couple of diseases that you can diagnose very specifically what they are. Strep is one of them, right? You can do a rapid strep test, find that it's strep. So when I say you have strep, pretty darn sure you have it. If I say you don't, pretty darn sure you don't have it. Urinary tract infections, you pee in a cup, we send it to the lab, very confident of my diagnosis of that. Flu, actually the flu tests are quite good and pretty confident on that diagnosis, and so is COVID. But the typical crud that kids get, and kids typically get 100 different kinds of crud in their childhood, we don't have a clue what it is. Some of these are adenoviruses, some of these are other coronaviruses, some of these are rhinoviruses. We just don't know. And so yes, we've seen people who have this low-grade fever, sore throat, coughing, nausea, and body aches. Some actually have COVID. So if you have those symptoms, please stay home, call your doctor, get a COVID test. Gabrielle says, does care at home like flus and rest make a difference in hospitalization and death? So what we do know that is underlying conditions. So the state you're in when you get the COVID seems to be quite predictive. So people who are quite otherwise healthy have a much lower rate of hospitalization death, and people who are less healthy, starting off dehydrated, starting off with a low oxygen count, do much less well. However, somebody bringing you chicken soup and a nice blanket so you can rest when you have it, nobody's done that study to see if that makes a difference, but it certainly makes me feel better when I'm sick when people bring me chicken soup. So Gabriel says, what are your thoughts on kids playing on the playground with other kids while wearing masks? So the story is playing outside is very safe. Again, we don't see almost no disease transmitted outside, and if they're playing on the playground and they're 6 feet apart, they don't even need to wear masks. If they're going to be closer than that, then they should be wearing masks. Then they should be wearing masks. But again, that's a low risk situation. Again, when we see cases, it's typically people who are indoors, close together, long period of time. Those are the people who are moving into others. So Brandy says, did they include children 12 to 15 who had autoimmune disease in the Pfizer trial? They haven't published it yet, so I don't know the data. So what will happen is when they submit to the FDA, then the FDA comes out with a position paper that was like 30 pages long that goes through all of that. So when that finally comes out, we'll take a look. So Kat says, several times you mentioned arthritis as an autoimmune disease. Does this include osteoarthritis? And so arthritis is the general term for what goes on. And arthritis caused by lots of things. Osteoarthritis, we think, is old people, the cartilage just wears out. It's not an autoimmune disease. It's just kind of an old age disease. But then there are other kinds of arthritis which are clearly autoimmune, things like rheumatoid arthritis or things like ankylosing spondylitis, all of which are there. So again, on autoimmune disease, there's a lot of autoimmune diseases, but typically for arthritis it would be rheumatoid arthritis or ankylosing spondylitis, It could be things like lupus, which can cause arthritis. And so it is a complicated field. And that's why there's a whole group of people, and all they study is rheumatology, which is joint diseases, mostly arthritis, because it is ridiculously complicated. So Brooklyn says, what if you had the J&J and you're a 36-year-old woman? How long should we wait to feel confident we won't get clots? So all of the reports from the clots have been in the first 3 weeks. So I think the earliest I've seen was 6 days. The latest I saw was 21 days. And I think that is what we've seen in these other things. And it's what we see with the heparin-induced thrombocytopenia, which this is a lot like, that it takes that long. So Brooklyn, if you can write in when you got the J&J. So if you got it less than 3 weeks ago, still need to be on the lookout. And what I would say is if a young woman got the vaccine and has anything funny, they should see their doctor. Because you can, the reason they reported this were two. One is there are things you can do. This is treatable. And basically what you do is you treat with a non-heparin, so other than heparin, kind of anticoagulant, and it seems to work very well. And then you give a kind of drug called IVIG, and that works very well. So there is a treatment. So what they wanted to be sure was that if people had symptoms, they got checked out, and then they could get treated. So that's why you would do that. Are we gonna have a lot of nervous people getting a lot of unnecessary CT scans? Probably, but who cares, right? Because if this were a loved one of mine and they said, I got the J&J 10 days ago and I got this terrible headache, I would say, let's go to the emergency room and have a CT scan, because that would help us to tell if that was what's going on. And the real reason they reported it is because typically if you had a clot, the right treatment is heparin. But in this case, heparin would be really a no-no. So that's why they wanted to get the word out today. And we did. We got the word out to every one of our vaccinators by noon today. We got the word out to as many people as we could talk. We distributed no more J&J vaccine because, 1 in a million is 1 in a million, but I don't think any of us want a 1 in a million risk, and that's why we were so cautious about this. So is there any information from the early trials of the mRNA vaccines about how long they'll prevent severe cases of COVID? Remember, those mRNA vaccines have only been out for 6 or 8 months. Both Pfizer and Moderna have results now to 180 and 209 days, and they seem to be really quite great. They seem to have high levels of antibodies. They may work even when your antibody levels go down, because I had measles back in 1963 or something, and I may not have a high level of measles antibodies, but I can tell you, if measles got anywhere near me, my body would remember back to 1963, and it would make this ridiculous immune response, and I wouldn't get measles. And so even if the antibodies levels go down, the cells may still remember this and still remember how to make antibodies. So what we said is that it really is, it's at least 6 months, but it's much more likely to be a year or more. So Debbie says, is it true that breakthrough cases are less likely to result in hospitalization if they get COVID vaccine? Debbie asks, that's exactly what the study showed. What we've seen here is that's also been the case in Oregon. So the rate of hospitalization generally is around 10%, and it's been lower than that with the breakthrough cases. So yes, we think in the breakthrough cases, you probably don't have a high enough level of antibody to prevent symptomatic infection, but you likely have enough antibody to prevent severe disease. Because again, severe disease usually is in people who have a really high viral load, and getting the vaccine, you'd have enough antibodies to maybe bring down that viral load. So have you heard of anyone having bad nosebleeds after the vaccine 2 or 3 weeks after? No, we haven't, although bleeding issues could be there. So I think if anybody has bleeding or clotting issues in the 2 or 3 weeks after you get a vaccine, see your doctor, easy test of platelet count to see if your platelet count is wonky. If your platelet count is not wonky, that'll be a good sign. If your platelet count is wonky, then we got some thinking to do. So we've not seen any of that. None of these cases that I know of presented with nosebleed. I think they presented with signs of clotting rather than signs of bleeding. Okay, well, she's collecting a few more things. There are a couple of really interesting things that we saw along the way. One is that more studies have come out about things that work and don't work for early COVID. So one question was about ivermectin. So ivermectin is an antiparasitic drug. We use a lot in our animals. And we use it somewhat in humans. You can use it for head lice, and you can use it for other kinds of disease. And so it's okay to use in people. And some places in the world think it's just magic for COVID. Unfortunately, the places think it's just magic is Brazil, and certainly Brazil has struggled with COVID, so I'm not sure I would ever follow Brazilian advice. There are some studies that suggest it does work, some studies that suggest it doesn't work. This was a very good study. It found people who had COVID, and then they gave them the ivermectin at the appropriate doses early on, and it did not seem to help. So I think that the data is piling up that ivermectin probably not useful. The other one that did was the Regeneron antibody cocktail. In this one, they gave it to people who were high risk, and it did seem to prevent progression of disease. So in terms of things that we know prevent progression of disease, is both the monoclonal antibody from Libby and the polyclonal antibody from Regeneron. Luvox, still up in the air. We're still waiting for that. Ivermectin, probably not. Hydroxychloroquine, probably not. Inhaled corticosteroids, probably not. IV steroids like Decadron, probably yes. One of the other things that came out this week was about prone positioning. This is the weirdest thing. So what we've seen in this COVID pandemic is that somebody said, well, this person's struggling to breathe. Let's put them on their belly and see what happens. And when you, usually in ICU, you have it laying down on your back and getting ventilated. But in this disease, they said, what about if we don't ventilate them and put them on their belly instead? And they had a remarkable improvement. And indeed, this has been shown now to be very effective to avoid intubation, is what's called prone positioning. And again, nobody knows exactly why this works, but it does seem to be great. And the good news is it's obviously safe, no big interventions, and it does seem to be pretty effective. So that's another one that does seem to be working. Other stuff, some of these anti-interleukin drugs maybe work a little bit, but again, we've not made great progress there. Okay, so I hear there's no more questions. That'll be good. And again, I'd ask people to be patient with the Johnson & Johnson stuff. I think what the feds did was exactly right. You had to tell people this was out there so that if somebody had one of these side effects, you'd know about it and how to treat it, and not fall in the trap of giving somebody heparin, because that's easy to do with this. And then we're going to take a little pause. And I don't know what they're going to decide. They might decide, look, we've got 2 other vaccines. We're not going to use the J&J. They may decide we're going to use the J&J with no restrictions, or they may decide something in between that we're going to figure out for certain groups. The risk of the J&J is very low and the benefit is very high. We'll give it, and for other groups not. So it could go any one of those 3 ways. And I have no clue at this point. I spent 3 or 4 hours on the phone today with different people talking about that. Nobody else has any better idea what's going to happen. So we're going to leave this to the feds. All right. Well, again, we're doing great here. I'd encourage people still to get the Pfizer and Moderna vaccine. We're going to have our next big flu event on April the 24th. It's going to be no J&J, obviously. It's going to be all Pfizer. And so we're going to do that then. And I encourage people to stay safe and be kind. Thank you.